Thank you, Dr. Farrell. I will note as we go along, jot down notes, keep mental notes to ask questions. We'll have the latter third of this session for your questions and discussion. And as we bring the next three of our four speakers up as well. Next, we will hear from Brynn Bowman, who we've met earlier. She is the co-chair of our planning committee and is the vice president for education for the Center to Advance Palliative Care. And she will talk with us about equipping mid-career clinicians with core skills for serious illness care. Brynn.
So thank you, Miguel, and I want to start with a quick anecdote that Betty may or may not remember, which is that the first time that I met her was in fact on a phone call within my first year at CAPSI, so it was probably 2014. And we were speaking because at that moment, you had been training and delivering courses for years at that point, and you were thinking about how to take some of that training online. And looking back, that was a big turning point, not just in serious illness care education, but in healthcare education, because the technology was getting good enough and accessible enough that we really could extend the education we were providing in that way. So I'd like to spend a few minutes talking about that today, talking about how we can use technology specifically to train the healthcare workforce that is practicing today and that is not working in the specialty of palliative care. So we listened all morning to projections about the size of the patient population that we will be looking at in the coming years, and we all agree that it is big and getting bigger. And what that means, or the implication, is that most of the healthcare workforce is going to be working with patients who have serious illness, and not just in the hospital, but also in primary care, wherever care is received. And it is the case that most of the clinicians in the workforce today who are practicing did not receive training in the communication skills required to have skilled conversations with patients about their goals of care, complex symptom management, or specifically how to support family caregivers. So clinicians who are graduating now may have had much more exposure because the vast majority of academic medical centers and of other teaching institutions in the U.S. today do have specialty palliative care teams. And those folks are being integrated into curricula. And so people graduating now have more exposure than they did coming out of school 10 or 20 years ago. But that leaves much of the workforce that's practicing today. So we really have an opportunity through training these mid-career clinicians to improve all of those clinical interactions. One study that I think justifies or speaks to the need for this training was put out last year by the John A. Hartford Foundation, the California Healthcare Foundation, and the Cambia Health Foundation. And of physicians surveyed, 70% responded that they had never received training in how to have compassionate advanced care planning conversations. And further, that those conversations caused them a lot of anxiety. We see this in the stories with our own families and our own patients. And so this is what we want to address in training non-specialists in core palliative care skills. So why does this matter? Nearly 80% of crisis emergency department visits and hospital utilization is based on uncontrolled symptoms. A paper published in the Harvard Business Review in 2015 found that of a number of variables studied, strength of provider communication was the single biggest correlating factor to readmissions. So when clinicians aren't trained in these skills and thus don't use these skills, the outcomes for our patients are poor. So what's the framework by which we think about this? Arif signaled this in his talk this morning, but we know what the unmet needs of our patient population are, and we need to train all practicing clinicians to be able to address those needs. And one of those skills to be trained is knowing when the situation is complex or intense, when it's appropriate to refer to specialty palliative care. And so we see this two-part framework. And back when I mentioned my conversation with Betty in 2014, CAPSI had been for 15 years developing technical assistance to support the design of high-quality specialty palliative care programs. and looking at the landscape and the workforce shortage and the growing patient population, we knew that it was time to also, not instead of, but also turn our focus towards addressing this training gap. We launched a curriculum in 2015, and it is a self-study online curriculum. And I want to acknowledge up front that not everything can be taught online, and not everything can be taught in a way that is not instructor-led. Communication skills, for example, this is particularly difficult, although we can help clinicians understand that they have perhaps gaps in their skill set and that it's possible to fill them. But in 2015, we launched this curriculum of online courses, and it was authored by an interdisciplinary group of experts, and it was intended to be taken by clinicians from all disciplines, from any specialty, working in any care setting. Core topics are very similar to what Betty listed in her prior presentation, so communication skills, symptom management, how to relieve suffering for patients as they walk through the disease journey for different diagnoses, how to support family caregivers. And we've approved all of these courses for continuing education credits for all disciplines, and we've tried to make it easy to use them by making them accessible on all disease types. So we've launched new units and new courses throughout the years, but this is where we started in 2015. Fast forward to today, and this talk was an opportunity to reflect on the really critical design elements that I think have led to the uptake that we've had and the engagement we've seen with CAPC's curriculum. And these are not specific to CAPC's curriculum. These are, I think, important lessons if we're thinking about ways to scale training strategies for practicing clinicians. The first I won't spend too terribly much time on because we talked a lot about it this morning, but interprofessional practice. So I mentioned that these courses were written by an interdisciplinary group of experts, and we know that it is absolutely essential that in the cases and the stories that happen inside of that learning, that they need to illustrate interprofessional practice. And so that's a core tenet, really, of any training curricula that we would create for this patient population. Second is motivation. I think unlike what Betty said about work stop style training, online learning is sitting in the background, and it is not the case that if you build it, they will come. You really need to make it to motivate both organizations to endorse or require clinicians to do training, and clinicians themselves to come back for more. So the ways that CAPC has addressed this are one is to make sure that clinicians receive continuing education credits when they take courses, that they receive them immediately so they are motivated to continue. We've also created a certificate called designation. So if you complete a full unit from CAPC's curriculum, maybe it's 5 communication courses or 5 symptom management courses, you get a certificate of designation, and you can put that on your resume. We encourage our users to use it as a differentiator in hiring conversations, and to be proud to be able to demonstrate that they have spent time and invested in that kind of continuing education. Adult learning best practices. I would suspect that most people in this room have had the experience of deadly, dull online modules, probably in a required compliance situation. And that is unfortunately the cognitive frame I think that most people have when they're thinking about online learning. It was very important to us that our courses feel nothing like that. And so we built them to be very interactive. We worked with instructional designers to say, how do we capture the attentions and the hearts of practicing clinicians who are incredibly busy, many of whom are not required to do this, but are doing it because they think it might be important or a colleague told them to do it. And so, for example, our courses are littered with quiz questions, and you can't proceed until you've thought about the patient case, made a decision to simulate your course of care. And we know that our clinician audience does not like to get wrong answers. And so this is one of the techniques that we've used to achieve engagement in our learning and make sure that learning is reinforced and then put into practice. And then finally, accessibility and ease of use. With technology, this is particularly important. If you fumble in your first interaction where you can't figure out how to log in, you can't figure out how to get through a course, you will leave and not come back. And the healthcare workforce has very varied comfort levels with technology. And so we need to make it as easy as possible for people to find the curriculum, to use it, and remove any of those accessibility barriers. So this has been, to some extent, successful. We're almost at the 5-year mark since these courses launched. We've trained nearly 50,000 people. They have taken more than 350,000 courses. Those courses range between 30 and 60 minutes. Almost 15,000 people have gotten that certificate of designation that I mentioned, which means not only did they take a course or two, they completed an entire unit. 90% of our users report immediately after they take a course that they're likely to change practice. I'm very excited to say that we've just recently started surveying users 3 months after they complete a designation unit. So if you complete all 12 hours of CAPC's online pain management training, you've gotten your designation. 3 months later, we send a survey to ask about practice change. And in the first cohort to respond, what we found is that they reported 9% of that cohort responded that they strongly agreed that they were comfortable managing their patient's pain prior to training. That 9% moved to 51% 3 months after they had done CAPC training. And so we see, this is self-report, but we see that clinicians find value in that training, even though it was online, and are able to and feel more empowered to care for their patients. So I show this slide not to show off, but to say that there's a very important trend here, which is that year over year there's been a lot more engagement. I know with our curriculum, we've seen with Betty's and with Jennifer's from CSU. So I think this is a national trend. And this reflects, I think, two things, both recognition on the part of organization leaders, leaders of provider organizations, that these skills are important and that there has been historically a training gap. And then also engagement on the part of individual clinicians. 2 years into CAPC's curriculum, we wrote one course on the care of patients with dementia and had hundreds of write-in responses from clinicians who took the courses to say, we feel like we have no toolkit to work with these patients. We have no clinical skills up our sleeve. Please write more content. Several years later, we launched a full 7-course unit on best practice care for patients with dementia, and immediately clinicians who had ever interacted with the curriculum came back to take those courses. So there is something in this, no matter which specialty you're working in or which type of organization you're working in, that empowers you to take care of gaps that you know have been there in your practice, and we hear that from our users. So that was a rosy picture. It doesn't mean by any stretch that we have touched the entire practicing workforce. And there are several barriers that we've seen, or things that get in the way of us reaching as many patients as we'd like to. And I want to quickly go through them. One, to date, effective training has been contingent upon a palliative care leader carrying that water. They are the person to go to their colleagues from other specialties, to their leadership, and say, this is important, we should be doing this. How much of the time do you think that those people have dedicated time for education in their scopes of work? Almost never. So this is a problem. It limits the capacity that we have for scale, and it contributes to burnout. And so the solutions here are really, all of us in this room, I think, have a stake in positioning palliative care leaders as thought partners with the leaders of their organizations and thinking about population health strategies for patients with serious illness, and education is one of them. And then what Arif mentioned about champions from other clinical specialties is incredibly important. We've seen that people like to follow leaders in their tribe, and this would help relieve burden on specialty palliative care leaders. CAPC has been putting out materials to help make this case and to ease the burden on those champions, and this is not quite out, but will be out in 2 weeks, a new monograph that makes the case for communication in pain and symptom management training. Tell your friends, sign up to our newsletter, and you'll be notified when it comes out, and please share it with everybody you know. A second problem is physician engagement. In February of this past year, CAPC did a focus group with physicians from specialties other than palliative care. Except for the youngest person in the room, they all said that they had had no exposure to communication or pain and symptom management training when they were residents. And Everybody in the room said that they thought that having that exposure would benefit their patients. They all also said that they would not participate in training voluntarily now because they had so many commitments on their time and so many other training requirements. The asterisks there were if you offered maintenance of certification points, that would help because those opportunities were fewer and far between than CME. And if they heard from a leader within their specialty, from their national professional association, that was the priority. So again, within tribe, that might make a difference. And so we are trying to pursue those strategies. This problem is to some extent a problem of our own making in the field of palliative care, which is as we were sort of branding ourselves as a specialty, in some ways we took ownership of relief of suffering. And the point I'd like to make here, and I know I'm running out of time, but is that language matters. You may have noticed, let's see if I can back up. In these materials that we're about to publish, Making the Case for Training, the word palliative does not show up on that title page, and that is intentional. We do not tell oncologists or primary care physicians when they're learning how to manage hypertension that they're doing primary cardiology. Why would we say that's the case for these palliative care skills? Very quickly, culture change matters here. Attitude is in some ways as important as the content. So we use graphic novels to tell before and after stories about what happens when patients haven't received care from clinicians who are trained in some of these core palliative care skills versus what happens when they do. And it's really important that we illustrate what can be better for clinicians in their practice if they get this training. And then finally, we all know that training alone is insufficient to create practice change. If I have been trained to have a goals of care conversation and I can't record it in my EHR, my colleague can't find it, or I have no time in my workflow or on my schedule to have that conversation, it doesn't matter how good the training was. And it's really incumbent upon leaders of provider organizations to ensure that clinicians not only receive training, but have the structural support to be able to use those skills. One positive indicator here is that the American Hospital Association partnered with CAPC over the last year and will be putting out story after story about the importance of prioritizing serious illness care to their membership of hospital and health system executives. And I think this is a kind of a leading indicator of change. The last thought that I want to leave you with is there are somewhere in the neighborhood of 4.6 million practicing clinicians right now, and Michelle Washko could check my math. Most of them, and not all, but most of them work with seriously ill patients sometimes in their practice. Before this presentation, I reached out to colleagues from other training organizations to get a sense for how many people we'd touched. CAPC has trained nearly 50,000 people using online training. CSU has trained 12.5 mid-career clinicians in addition to the tens of thousands of pre-professionals that they've trained through their programs. VitalTalk has trained 10,000 clinicians and have another 550 faculty who are conducting trainings in their own organizations every week. Respecting Choices has trained 27,500 clinicians to have advanced care planning conversations and another 10,000 trainers. The Serious Illness Care Program has trained more than 13,000 clinicians to have serious illness conversations and are building an extensive pipeline for their trainers. And as Betty mentioned, LNEC, in addition to the numbers she already cited through their courses and workshops, have trained another 75,000 clinicians using their online curriculum. We know that we have overlapped in some of these cases. Organizations who recognize this is important engage with more than one training curriculum. So we can't know for sure, but maybe we've hit 10% of the practicing workforce right now, maybe 15 if we're feeling very optimistic. It's not enough, but it's enough to tell us that this is possible and that we can keep chipping away. So my final thought would be we know what patient needs are. That does not need further study. We know how to deliver training. We've heard from several people already today from different effective mechanisms, and it's time to execute.